And so you mentioned high-risk patients. Swetha, how do you approach the first-line patient? And how do you determine high risk?
Yeah, so I mean, in terms of treatment versus watch and wait, I think about GELF criteria, whether they're symptomatic and that would warrant treatment. And then in terms of high risk, we need more predictive markers at the time of diagnosis to really tailor the therapies. As Loretta mentioned, there's rituximab, there's chemo, there's now novel agents. So how heavily do we treat patients? That's still something that I think we need a better understanding of at the time of diagnosis. But in terms of whether to treat a patient, I often use the GELF criteria, but I think how aggressively to treat the patient really depends on their symptoms, how extensive the disease is. And then, of course, when they're more relapsed, we think about early progression of disease, or POD24 as a marker of high risk.
So neither of you mentioned R-square. Does anybody use R-square in the frontline setting? Jason?
We do sometimes. I mean, it is definitely a therapy that's often more a second-line treatment, but in the frontline setting, it's got some utility. I think the complexity that you've heard here is true at every center, that you've got a different version of what they consider to be a frontline or a second line, and there's mixtures there. And so I think the ability for the early data so far for golcadomide to work in patients who've had prior lenalidomide will be very important, because there's going to be a lot of heterogeneity in terms of patients had prior len. Was it in frontline? Was it in second line? Was it beyond second line? And so seeing golcadomide enter the landscape, it's nice to know that it can work even if somebody had frontline lenalidomide.